So this topic is quite important, I think, and I will not be able to provide all solutions, but I'll try to at least describe the problem. So one thing I was kind of, it became like a revelation because I always say benefit risk. And then I met someone who said, what, shouldn't be the opposite, risk benefit? Feel how you say it, benefit risk or risk benefit? What's the best? Do you have a preference? I did a little search. So there's a narrow win for risk benefit. For all I know, it could be relating to investments in cryptocurrencies or something else, not medicine. But still, I think this, I mean, we have to see the two sides of the coin. And then, just before jumping into things, we get the data. We want to build our decisions on, or when we calculate the risk-benefit, we want to build it on robust science, and then, of course, we start to look at the top. So randomized controlled trials is the golden standard for evaluating safety and effectiveness. But there are some problems. So first of all, it's just a subpopulation of the entire group of people with a certain disease. And we have to look at endpoints that are not very rare, and they must happen quite soon. In MS, usually within 2 years, during the duration of a typical phase 3 trial. On the other hand, we have a rather diverse group of kind of real-world evidence that you could, layer also in terms of robustness and the quality. But as a group, it's quite difficult to interpret real-world data, and you have to read quite carefully what exactly has been done. And there are some pitfalls, like confounding by indication, of course, but also surveillance bias. And reading papers is one thing, but reviewing papers, you see really, why not include an epidemiologist or someone knowledgeable to make your study design? So there's a lot of not very robust science published regarding real-world evidence. So to make a case regarding benefit risk, we'll look at B-cell depleting therapies. And of course, you could look at any type of therapy and make such a list. But I think B-cell therapies is the most important drug class in MS, I would say, right now. And we have 3 approved treatments. One came just very recently with quite little data so far. But of course, I'll also include rituximab, because the good thing with rituximab, it's been used for rheumatoid arthritis for close to 20 years. So, and we have a long experience of using it in multiple sclerosis too, meaning that we can have longer exposures. So looking at the gold, the hard currency, the Swiss francs regarding benefit risk. So in relapse and remitting MS, the OPERA trials, and you can see the mean age and the EDSS, relapse and remitting MS, there was a highly statistically significant suppression of relapse activity, and even more so on MRI activity. And there was also a significant reduced risk of disability progression, and no difference in, safety issues were not that highlighted. No difference in rate of infections. And then in PPMS, an older group, but quite young still, 44 years, but also with a higher disability. And here there was a there was a statistically significantly reduced risk of disability worsening, but the absolute risk reduction is quite small. And let's see now, there was also a numerically higher number of severe safety events, but it's hard to really relate to this if you have like 3 people in one arm and one or no person in another arm. Statistically, it's tricky. could be by chance. So this is what is highlighted in the SMPC of Ocrevus. So should not be used in people with active cancers or perhaps even in people with a higher risk of malignancies. And then it's also stated this thing about infections. But what to do with that information? And then jumping into the other drug, ofatumumab, quite similar patient composition and quite similar results, though also here serum neurofilament was up, so that was reduced too. No difference in rate of infections. And then a small trial would like anyway to highlight, so just 200 people, but look here, new onset. So a younger population, lower disability, comparing rituximab to dimethyl fumarate. And then here there was a quite significantly lower relapse risk, but the annualized relapse ratio was very, very low. So of course it's difficult to know, but perhaps indicating that early onset MS is, you see, you can reap greater benefits of the better treatment. Of course, too small to say anything about disability, but also being a slightly more real-world study run at smaller neurology clinics in Sweden, there was also the biggest difficulty, I would say, was to keep people in the trial on drug with DMF because it's hard to mask and due to the side effects that is not dangerous, but quite common, and many people don't like them. So when we start to look at the evidence from the real world, I'll focus on 3 scenarios because I think it's important also to look, when we meet people in the clinic, we have different types of clinical scenarios. So starting from new onset, so we had different practices in different parts of the country, and it's still so. If you look in different countries, I mean, we still don't do the same. So I think there's a lack of common consensus of how to best to treat. So in northern Sweden, they quickly turned to rituximab, and in Stockholm we did, as in many other places, we choose what we thought was best and trying to individualize treatment. But looking at the whole group here, so the bottom left here, we can see that more people stayed on rituximab. And if you look to the right, you can see reasons why to switch. So it was both disease breakthrough adverse events, and with natalizumab, of course, mainly being positive for GC virus, meaning that it seems to be a good drug for new onset. And then a second study looking at people that had injectable interference or glatiramer and had disease activity, and they switched to natalizumab, fingolimod, and rituximab. And natalizumab and rituximab were the best to suppress disease activity, but also incorporating drug persistence, being staying on drug, then rituximab was better. And then I think this study was important because, at least for me, when I saw the data with high disease activity, high inflammatory disease activity, and I think going off natalizumab is a way to look at people risk having rebound activity. And here we compared fingolimod to rituximab. Gothenburg mainly used fingolimod. Northern Sweden, rituximab. In Stockholm, we had 2 hospitals. One, my hospital, was rituximab, and the southern hospital, mainly fingolimod. It was a big difference. So hardly any relapses on rituximab, and about 30% had relapses within a year and a half on fingolimod. So it's a highly effective, B-cell depletion is highly effective. And this impacts even, well, caution, this is real-world data from the MS registries, but still, I think, pretty good MS registries. Comparing Denmark to Sweden, and Denmark, in the Nordics, they've had the hardest regulation. So 80% should start on teriflunomide, and then they switch to dimethyl fumarate. And after this study came out, they now switched to ofatumumab. But I think it's still interesting how what we do in the clinic impacts at the national level. So there's a higher proportion being free of disability progression in Sweden and a higher proportion being relapse-free. So again, arguing that high effective from start is better in the long term. And this study we did with a more kind of structured, so these people being participating in this Combat MS trial have been more followed more carefully. And here we have in mean more than 7 years of follow-up and looking at, I mean, how is disability evolving over time, and also this symbol digit modalities test, which is a kind of a little bit, let's say, looking anyway at cognitive functions, at least superficially. And it seems quite stable, surprisingly stable over time, at least much better than what my kind of clinical experience from working in the first decade after the 2000. So mainly people starting their first treatment when they're older and with at least a moderate EDS score, they risk worsening, whereas people with a low degree of disability in young people, they do fine, at least for the first 10 years. So conclusions. So B-cell therapy is looking at benefit. It looked comparatively quite good, at least with relapsing and remitting MS. And of course, we don't have many approved treatments for PPMS. And looking at real-world data gives support. So B-cell depletion looks good from many points of view. And then last point, no existing randomized control data addressing differences between different anti-CD20s. Of course, maybe I didn't have time to bring up here. There's some real-world data suggesting differences. I think we have to wait randomized control data. The Norwegians are doing a trial, and the Danish too. So hopefully we'll get better data. But then the second side of the coin, the other side of the coin, the risk. So from RCTs, we see no increased risk of infections. But whatever we do with that information, slightly more cases of severe infections and also malignancies. So something we have in the Nordics, we have a long tradition of publicly funded healthcare and also early start of registries. So everyone being hospitalized or even outpatient visits, every prescription made by a physician, even GPs, is logged, so you can get that information. The problem is to identify, if you want to look at multiple sclerosis, of course we can identify those based on ICD codes, but we don't know really what type of MS, and there's a lot of things we would like to know. So by linking data from the MS registry, where we have data on EDSs, relapses, patient-reported outcomes, and so on, to a series of healthcare and demographic registries, including education and where people were born and everything, we can get a much richer data set to correct for, and then we can say we have probably less confounding by indication. So looking at cancer first, so we looked at people starting a first treatment start with 3 drugs and comparing them to a large MS-free population. And then we can see that, well, no drug really increases the risk compared to population-based controls. It was a borderline significant result for fingolimod, but MS patients, the people we look at, are fairly young, so there are few events, so I would take that with a grain of salt. But at least it's good to see that B-cell depletion, the point estimate is actually on the right side of 1, so really no indication. We also looked here at basal cell carcinoma and dysplasia of the cervix, because those could be related to especially the later HPV infections. Wide confidence intervals, but no signal for B-cell depletion. And here looking at breast cancer, so the incidence rate per 10,000 people was clearly not increase compared to the general population. In fact, a little bit lower. So this looks good. There's no signal for prostate cancer, melanoma, non-melanoma skin cancer, or lymphoma. But then we come to the problem. So we saw this before COVID. And here, comparing Ritux to fingolimod and natalizumab, and also people being on injectables and the general population. These are not corrected for baseline differences, but if we go to the tables, we can say that corrections making the model more complex and involving more factors reduces the relative risk increase with anti-CD20, but it's still significantly elevated. So 0.7 for hospital-treated infection versus being on interferons or glatiramer. There's also an increased risk, but a lower increase for antibiotics use. So here we pick up also milder infections. But interestingly, with people picking up a prescription for an antiviral, herpes antiviral, then it's fingolimod and natalizumab that's clearly different, not anti-CD20. And to express it differently, if you look at Ritux as the reference, then there's a lower risk for serious infection on injectables and also on natalizumab. Antibiotics use lower with fingolimod than interferons, but it's actually a lower risk for having viral infections. Yeah, pretty much summarizes that. And then this question, does infection risk increase with increasing time on anti-CD20? What do you think? So make an answer in your head, yes or no, and keep it, remember it, and both are correct. But it's, you know, it's difficult being a clinician from the origin, you know, this how to handle risk is a bit tricky, so I'll explain why it's tricky. So if you look at the data available from the real world, remember we have limited data from randomized controlled trial. There's no risk increase. But there's some papers now coming out that highlight, okay, treatment duration is the most important cofactor for infectious risk. And then you talk about hypogamma also, of course. But if you look here, the hatched line here is the actual hazard risk for a first infection. And it stays pretty much the same, about 2, a doubled risk. Up to data gets a little bit shaky in the later years, but 5-6 years, you doubled risk. But the accumulated risk, of course, go up. So it's the same like with PML and natalizumab. So perhaps the risk doesn't go up, but the accumulated risk is much higher, and curves will divide more. And this is what you see here on this, the proportion being free of infection. Yeah, it's both yes and no. What about the impact of prior treatment history? And this is not yet published, but I think it's important. I thought so. I thought that I had the clinical impression that people coming off natalizumab or fingolimod had, or DMF had a greater increased, I mean, maybe greater risk of hypogamma, and you know, but we can't really pick that up. So starting at the CD20 first line or later line, it's more or less the same. Outpatient infections too, and systemic antibiotic and antibacterial treatments the same. And then looking specifically at different drugs, well, there was a borderline significant result for coming off interference, but otherwise small differences. So this affects also people, not treatment-naive people. And then comparative risk COVID. So we've seen a number of publications. This is only one. So fusing a lot of data, more data is better in one way, but it's also more difficult to kind of control for differences. So here, anti-CD20 is elevated compared to DMF is the control, but also fingolimod, perhaps the lowest point estimates. But look here, the untreated group is higher. So it's significantly higher risk of having being hospitalized for COVID if you're untreated compared to DMF, and that's very hard for me to understand biologically. So likely some degree of residual confounding in spite of the corrections they made. So we did a similar study, a smaller material but nationwide data, and then we adjust for many more factors, including prior health history. I think that's important. And also many other things regarding MS phenotypes and so on. And then differences are smaller. It's still, with natalizumab, it's better, if you're on natalizumab, you have a significantly low risk of being hospitalized with COVID compared to rituximab, but the rest is, a moderately increased risk, not significant, but point estimates. But then on the other hand, there's some benefits too. Risk of PML. So to the right, French data. So they have seen it's not climbing, it stays stable at about an incidence rate of 2 per 1,000. In Sweden, it just shut down because we started to switch people on except a stupid clinic in Western Sweden that had a person with high GCV. Yeah. So here, if you calculate, we would have had, if you look at like 2, it's maybe 10, 15 people that could have had PML if not, changing, switching. Again, showing that, what we do will affect people's lives. So the adverse effects outcomes, the risk side, so a clearly increased risk of severe infections, but not typically opportunistic. It's more bacterial infections, respiratory tract and urinary tract. We didn't talk so much about hypogamma. I think IgG levels is a rather modest. It's a proxy for infection risk, but it's not a good proxy. And we don't know really yet if there's a big difference between different anti-CD20s. But the good side of this, there's actually no indication for an increased risk of cancer. That's good. So what to do then? Before COVID, when we saw this, so to the left is a complex picture, and you can't find it in the publication, but it's, I think it tells you a bit. So it starts from 2012, and it ends at 2021, the horizontal axis, and every line, there's 718 lines, everyone is an individual, and the yellow spots are infusions with rituximab, and you can see every 6 months people come in for an infusion, but then the upper black arrow, the fall of 2019, we decided we have to do something about the infection risk, so we started to extend people having had anti-CD20 for more than 2 years. But then COVID hit, and then we just made a risk-benefit assessment, and we said, we just stop. Or extend long. And the red triangles are people reporting a relapse. And if you look at that, the biggest problem here, there are too few relapses. Then it makes data, it's tricky to analyze. So it's 0.01 relapses per year, and it doesn't increase the point estimate, but the confidence interval is wide. And you see on the lower left here, the B-cell levels doesn't correlate at all with disease activity. Now I must say, we looked at MRI, lesion accrual. I would like to have NFL on this too, so we're collecting now when we have even longer time. So we have switched to 2-year intervals, 500 mg of rituximab. It's a drug cost of 100 Swiss francs. It's not a huge problem in Sweden, even less so in Switzerland, but abroad. And if this also, we know already that it gives better vaccination responses. So our people, if you wait a while, you get as good antibody titers as without anti-CD20. So we want to look at infection risk too. But then this is the big problem now. What's not inflammatory driven? What about DMT effects on disability not driven by inflammatory disease activity? Because what we see in randomized controlled trials, the biggest benefits are among people aged 40 or younger. much less benefit if you're over 40. But what about people being like me over 40? I mean, what benefit do we have? And this was stolen from Jens' presentation and Pascal's presentation last ECTRIMS. And you can see to the left here what happens with NFL. So people not progressing, they lower their NFL levels. There's a smaller but not really convincing decrease among those that will later progress, and GFAP doesn't change much. So what do we do with our B-cell depletion in people being a little bit older? And then the question about relative versus absolute risk. So now we just talk about the risk ratios, hazard ratio, and of course if you have someone like 25-year-old man or woman, maybe there's a 1% risk of having a pneumonia the next year. But if you have someone who's 58, maybe chronic bronchitis, maybe the risk is 15%, and then a doubled risk will be, quite much different. The absolute risk increase will be much higher. So I like this quote because it's, I think, still, I mean, we do so differently. We haven't really managed to implement a good benefit risk or risk benefit analysis for our patients. And they are a quite heterogeneous lot of people. I mean, there's many, many different things we have to consider. These are just few. And also, most of all, people, the big problem we have with benefit risk or risk benefit is that it's not being slightly neurotic. It's not me taking the risk. It's someone else taking the risk. And that is a burden to carry. So schematically here, going from adaptive immunity to perhaps innate immunity or neurodegeneration, we see a lower DMT efficacy, relative benefit. So what's happening here is we have a shift in benefit risk to risk benefit over time. We have to use both ways of thinking here. So in some people, we start with, we need to talk treatment, we start benefit risk. And in other people, perhaps being on a drug, we have to talk about risk benefit. And there's other things we can do. There's many other things we can do. So it's not just taking off a treatment. So over 40, the relative benefit of physical activity, vaccinations, lifestyle factors, and treating comorbidity is so much bigger. And also consider DMT de-escalation. And perhaps, though, lower right, we don't know. But meanwhile, the other things are really, we have the data at hand really now. So usually I tell my patients, if they're younger than 40, that I don't care much if they, engage in regular physical exercise. But over 40, and especially if they're 50 or older, you have to exercise. That was that.